Hi, my name is Nick. This video is for the students who are going to be with us next week. And we're sitting in our minivan. I'm with the health coaches, Amit, Beth, and Alicia. So this is our super playbook. The super stands for Super Utilizer Program for Engagement and Recovery. And let me just take you through it. So our mission is to have fun. That's basically it. Well, also to learn, to work with people to build habits, and to help a person find solutions rather than be the solution. So the background of this is this Maslow's hierarchy of needs, and it shows health as one of the core fundamental needs for a person to be able to survive and thrive. And what we've learned is that your health is influenced in large part by your childhood experiences. So this is the adverse childhood experiences study that showed that if you had 4 or more exposures to childhood trauma or violence, your risk of all these health-related process and outcomes was significantly greater than a population without those experiences. So the healthcare system in the United States is the most expensive in the world, and the quality of the healthcare that we get ranks far behind countries that pay a lot less for their healthcare. What we pay for and the fact that we pay more and get less for our healthcare has been referred to as the American healthcare paradox. And there's a couple reasons that have been described for this situation. So one of them is that although we're spending a lot more on healthcare, the ratio of healthcare spending to social services spending is much higher for the U.S. than countries with much better health outcomes. So we spend 50 cents for every dollar we spend on healthcare. We spend 50 cents on social services. And you can see it's the lowest ratio of social to healthcare spending of industrialized countries. Another reason that healthcare is another reason attributed to the poor health outcomes we have in the U.S. is a shortage of primary care and a payment system that incentivizes high-tech solutions and quantity over quality. So setting out to improve healthcare has been described as focusing on aims. So there's the 6 aims of the Institute of Medicine: safe care, efficient, effective, equitable, patient-centered, and timely. There's the triple aim of the Institute of Medicine, where you strive for improving the experience of care, the health of a population, and reducing the per capita costs. So there's also some proven ways to innovate, to improve. They are the Institute for Healthcare Improvements, or IHI's model of improvement. And there's a lot of borrowing right now from the manufacturing sector, specifically lean manufacturing, in informing how we innovate in healthcare. There are some great examples of how healthcare is innovating to achieve these aims. Examples are the Camden Coalition, Health Leads model, the Collaborative Care model, Assertive Community Treatment, Partners in Health, and IORA Health. So our journey is mapped out right here. We started with using lean manufacturing principles with build, measure, learn, and rapid PDSA, rapid iterative tests of change. We've developed a model that's based on a customer archetype, and we have a value and a growth hypothesis. So if you look at our journey, we began with this idea I began thinking, let's go after many patients who have particularly bad health outcomes and particularly costly care, called super utilizers. Let's call them at home, focus only on the patient, see them in clinic, have schedules that are far out, put social and psychiatric needs as peripheral to the intervention, deliver it through a physician, look to give more care, find a deficiency in the care they're getting and add to the care they're getting, and rescue them. So go out there and save them from a bad health outcome. So this is the journey. So we went from many patients to a few. Learning the stories of a few patients was going to give us a better insight into the problems that healthcare had with all of the patients rather than focusing on many. We meet at the bedside. So calling someone after they've been discharged is a lot different than meeting them when they're having a crisis. And it's a lot more effective to get engagement when you're offering somebody a solution to a problem that they're facing at that moment. Including family. So focusing just on an individual and ignoring their social context and their family is a way of handicapping the kind of changes that can be sustainable in their lives to promote better health. Seeing them at home as opposed to coming into the clinic is a better way of understanding them and a better way of engaging, and it's more consistently successful at connecting with people. Scheduling visits in the short term rather than expecting someone to be there for you in a week or two, just probably due to some of the chaos of the people we're engaging. We have much better success when we don't expect a commitment to meet in a long time, but rather short-term scheduling. Front-loading their social issues. So at our hospital, we refer everything that has to do with your social or psychiatric needs to another institution. And not only does that make the care more difficult, it also shows that we don't think it's as important. And it is impossible to work on a patient with diabetes if they can't read the label on the insulin that they're taking. So ignoring social issues comes at the peril of their health, or not ignoring, but even referring social issues comes at the peril of their health. So we've recognized that there are certain things that you can't even that you can't put to the side if you're going to get to the root causes of what's causing a poor health condition. Asking people to do more. So rather than thinking about what healthcare can do more, so do we need another visit? Do you need to come and see us more? Do you need to call us? Do we need to have a nurse come out to the house? Instead of looking at all the things that we're doing and adding more to that, let's stop and look at what a person's doing. What that 99% of their lives that they're not in healthcare, how do they live? And that's going to be the source. The change that happens in how they live is going to be much more powerful than any change or addition from healthcare. So going from a delivery model of a doctor to a delivery model of a coach. So if this is really about what people do in their homes, and there is such a shortage of primary care physicians in the world, and there's such an abundance of people who want to change the world and who are inspired to care for people, then we have found a great resource and a great opportunity by expanding who can be engaging people in the life changes that can change the trajectory of their health outcomes. And then finally, this idea of habit building, that waiting for problems to arise to address them and waiting for medical solutions to everything is far less powerful as a way of changing than instilling in people basic habits that can promote health as well as success in any endeavor. So our customer archetype arose from this 5 whys, which is a lean manufacturing principle, where you ask 5 questions when you have a problem and you get at the root cause of the problem. So here's our customer. He's unhappy. He's saying, I keep getting hospitalized. So the first question is, why do you keep getting hospitalized? Because I get short of breath and have to call 911. The second why do you get short of breath all of a sudden? Because my heart failure is out of control. The third why is your heart failure out of control? Because I can't do everything I'm supposed to do to control it. Question number 4, the fourth why can't you do everything you're supposed to do to control your heart failure? Because I can't remember. The fifth why can't you remember to do everything you're supposed to do to control your heart failure? And here I have 3 reasons that we've seen: cognitive impairment, distraction from stress, and secondary gain. And so they combine here in this Venn diagram as often overlapping causes for someone not being able to do the basic things to prevent a crisis in their condition. So our value hypothesis is that there are daily habits that make the difference between the chaos of being a superutilizer and the control of those who are healthy and successful. As long as we are focused on the downstream effect of habits, or limit our interaction around habit formation to the people to people when they're in front of a doctor or are hospitalized from a condition, we're not going to really be able to address the cause of the utilization, which is the habits they do when they're at home. So by focusing on basic health and success promoting habits and working with people over time to adopt these habits, we can address the root cause of health problems and promote personal success for individuals extending beyond their health. So we do have to address basic needs before we can focus on habits: housing, food, health insurance, income, in order to allow someone the space to focus on habits in their lives. And we can't impose behavior change, so we need to be able to uncover intrinsic motivation for a person to adopt new habits. And this is made possible by a non-judgmental, affirming, and facilitative engagement approach that the health coaches use. Some people have cognitive impairment, and that necessitates others in their lives assisting them with learning habits, and we identify and engage these social supports. The role of the coach is not to help a person find the solution. The role of a coach is to help a person find a solution rather than actually be the solution. And so the mantra of a health coach is, how would you do this if I wasn't here? So our growth hypothesis are that health coaches, non-licensed, enthusiastic, idealistic, energetic people, are an abundant population. These individuals are ideally suited to work with the population at the root cause of poor health, their poor habits, and improve the overall quality of healthcare while reducing costs, improving the patient experience as well as the health of the population.